Okay, good afternoon, everyone. Thank you for joining, and happy National Rural Health Day. We're really excited to be celebrating with you and these webinars today. A couple of housekeeping for the webinar. Attendees will be muted during the presentation. However, the chat is enabled, so we encourage you to enter any questions that you have in that chat. Additionally, the webinar is being recorded. That'll be posted on our website and then shared via email with you. So feel free to share it out if anyone else may be interested in this content. Then we would like to take a moment to respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Odom and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And I'd like to give a shout out to our co-hosts for this year's webinars for National Rural Health Day. If you'd like to scan the QR code on the screen, you can learn more about the Arizona Rural Health Association, as well as membership opportunities to engage with them. And with that, I will hand it over to our presenters for the day.
Thank you, Mariah. I am going to just set up the slides. And I will be with you in 1 second. Screen. Okay, I think we are in business. And Mariah, you're going to manage the chat for us?
Yes, I will manage the chat and the slides look great. Thank you.
Okay, excellent. Thank you for reading the land acknowledgement. I'm going to pass over our slide. I did include it just because part of our travels have been to several of the sovereign nations, and so it has been really important to include that. We have no disclosures. My name is Dr. Erin McMahon. I'm a certified nurse midwife and the midwifery program director here at the Melanina Zuckerman College of Public Health. And I would like to introduce Jill Bullock, if you want to tell everyone a little about yourself.
Hi, everybody. I'm just trying to turn my camera on and it won't work. So get to see my face on the photo. I'm the Associate Director here at the Arizona Center for Rural Health, and I've been here 14 years. And oh, now I'm going into and here is a link to our fairly recent annual report. And the Arizona Center for Rural Health since 1980 serves as its core mission to improve the health and wellness of Arizona's rural and underserved populations. And in this portion, I'm going to talk a little bit about what the Arizona Rural Hospital Flexibility Program is. That's a program that, if many of you don't know, it's a program run through the Federal Office of Rural Health Policy to support our critical access hospitals in the areas of quality improvement, finance and operations, population health, and EMS and trauma. And we also help our designate critical access hospitals or de-designate them if we have to do that as well. So you can go to the next slide.
Okay, great. So I'm going to take over for a little bit, and there's a couple things we're going to go over during this session. I always feel like it's important to really level set the content about the maternal mortality crisis in the US and look at the data in Arizona, because that helps lead to how we got to the need for these simulations at the critical access hospitals. So this is a slide from 2020 that I just love to use as a visual, because what it really demonstrates is how the United States has been doing in terms of maternal mortality rate compared to our European colleagues, Australia, New Zealand, and you can see that it is abysmal, despite the fact that it is well known that the United States spends more money on healthcare than most other countries. So, and as we're considering around rural obstetric care, that there are over 2.2 million women in childbearing age that are living in areas that are considered to be maternity care deserts, or where there is no obstetric hospital offering, no birth center, and sometimes there's not even a provider in their community at all. And at least half of all rural community hospitals are not able to offer obstetric services. And I say that very intentionally because this is not a matter of not wanting to, not thinking it's unimportant. It's a matter of the fiscal sustainability of operating a labor and delivery unit. And we're going to talk a little bit more about that at the end of our session and our time together. During the 10-year period between 2011 and 2021, about 267 rural hospitals were forced to close their OB services, and that accounted for about a quarter of all the rural OB units in the United States. And as we know, those numbers are just continuing to get worse. As we look at maternity programs, about 400 closed nationwide between the time period of 2006 and 2020. And of course, in our rural communities, the disappearance of OB services has been particularly impactful, as you'll hear a little more about. So the need for simulation training, which is something that I'm passionate about, but that was evaluated by Gilbertson et al. In 2020 in a survey of rural hospitals, and they identified 3 content areas that they felt would be really critical and important for their staff, and that was training around precipitous or very rapid labors and births, around postpartum hemorrhage management, and then around the resuscitation of the newborn, or NRP trainings. Now, some of the slides we're going to look at, depending on where you're from and what your background is, this may be very familiar to you, but this is one of the Center for Rural Health maps about our rural health safety net, so where our critical access hospitals are, and other like community health centers, where are the IHS hospitals or 638 sites, tribal clinics. And I always find it really impactful to note, especially when you're looking at Arizona, that there are large swaths and counties that have almost very, very limited health care in them. Especially, I highlight southwest Arizona. So there's OB services, obviously, in Tucson. And if you go west, you have to go all the way out to Yuma to find the next obstetric provider. If you go south from Tucson, we've got Holy Cross in Nogales. And in Cochise County, there is Canyon Vista and Sierra Vista. But so Santa Cruz County has one place for OB services, and Cochise County has one. Mount Graham Regional Medical Center in Graham County. But that means that women are driving upwards of an hour or longer, even in the southern part of the state. And those times and mileages are very similar, sometimes worse, as we look at northern Arizona. So this is another image from the 2020 workforce report that looked at OBGYN physicians and CNMs by county. I know you can't read those specific numbers, and really I just want the visual of the colors of the blue. So the darker blue is where the medium and darker blue are where we have the highest concentration of providers, not surprisingly in the central parts of the state where our more urban communities are. But of note, Graham County actually at the time of this had one OBGYN. I think there are 2 there now. One CNM, her name is Nicole Mortensen, and she is lovely, but would like to have some other colleagues out there. But counties like Greenlee and La Paz have 0 providers. There's not a physician or a CNM in those communities. Going to move on. Now, the maternal mortality data in Arizona, this is the hot off the presses report from Arizona DHS that we've been waiting patiently for, but the Maternal Mortality Review Committee has been working through the most recent data of 2019 and 2020 and added this. So the news is not good, but we appreciate the timing that it takes for that committee to really work through all this data. So in the 5-year period, and this infographic on the right where I have highlighted that a little bit is in this report, which you can find on a really quick Google search via Arizona DHS. But in the 5-year period from 2016 to 2020, they have identified and reviewed 3 363 pregnancy associated deaths in our state. 363 women that have died. About 28% of those deaths were determined to be pregnancy related. So that's just about 100 women in that 5-year period that we know the cause of death was related to the fact that they were pregnant. Now, about 17% of the 363, they were unable to determine that. So some of those were pregnancy related, some of them may not have been. So that 28% or those 100 deaths, the number is very likely a little bit higher than that. Now, the other shift we've seen, I'd say, in the last 5 years or so is where cardiac issues, infection, postpartum hemorrhage have been the leading cause of death for maternal mortality in Arizona and the nation, quite frankly. It has shifted more recently where mental health diagnoses or conditions are the leading cause of death. And that includes suicide, intimate partner violence, substance use disorder, issues around postpartum depression, anxiety, and psychosis. And we also find when we look at race and ethnicity that American Indian women in the state of Arizona and Black women are disproportionately affected in these numbers, and upwards of 2 to 3 times the risk of death compared to their white colleagues. And then at the very bottom of that infographic on the left, I just want to highlight that of the pregnancy-related deaths of those 100 women, the Maternal Mortality Review Committee was able to identify that about 85% of those deaths were considered to be preventable. Now, as Jill and I traveled, and we will tell you a little bit about the simulation trainings that we have been doing, but we did meet a young woman in a very rural part of northern Arizona out in the community who was pregnant. And we asked her where she was planning to give birth because we were talking about her pregnancy. And she shared with us that she was supposed to go to one of the OB hospitals in northern Arizona, but she wasn't sure she was going to because it was way over an hour. Transportation was difficult for her family, and that she was very likely going to just go to the critical access hospital that was in her community, which was very small, a 4-bed facility, non-birthing facility. And, that was our personal experience, but this is a quote from an article from some of our colleagues at the College of Public Health here. I would have gone to a different hospital if we'd had the option, but the closest hospital is over 100 miles away from other hospitals. So I just stayed and delivered here. So that's from their research looking at optimizing postpartum care in rural communities. But it's definitely been the experience that we've had with our N of 1 of communicating with folks. But Jill, if you can hop on again in a little bit and say, okay, we're in this crisis, but how did we come to where we are with our trainings right now?
Happy to do that. So, um, I think it's a couple years ago now, I heard a presentation by the medical director of the Federal Office of Rural Health Policy on how we could um, work on maternity, births, deliveries, maternal health through our Flex grant under the population health piece of our Flex program. And so I had this aha moment that we have this beautiful new midwifery program here in Arizona. And I got in contact with Erin and I said, how can we take this idea and train our non-birthing critical access hospitals? And Erin loved the idea and we ran with it. So Erin and I have been going around the state. I think we've done 9 hospitals so far. And we have 5 of our critical access hospitals out of 17 that deliver babies. So we do have a very big need, and we have 2 hospitals, 2 critical access hospitals in La Paz County, and there's no OB services there, and so that was definitely a targeted hospital to bring this training to. But so we hadn't written this in our work plan that year. And so I brought this idea up with the Arizona Rural Health Association. How can we continue this project? Because we really hadn't budgeted for it. And so Elizabeth Kaiser, who's one of our, who's on the Arizona Rural Health Association board, wrote a grant and to NRHA, the National Rural Health Association, and it was funded. So the funds for continuing the project really are including the evaluation and bringing along another midwife to help support the training. So um, it's been a fabulous project for me personally. It's been a highlight of my career. It's really fun to do. I love going out with Erin, and I know how to deliver a baby.
Yes, you do. We've got it on film too. Yeah, and I want to formally and publicly thank you for approaching me about this to say, hey, can we do simulation training? Do we have to bring people to Tucson? Because we've got great space here on the U of A campus. But during COVID, I'd had the experience of having to travel to where some of my learners were. And I said, absolutely, we can take this show on the road. And so we did. So we started a pilot, and we realized at our first training that it was really important not to skip the basics. And there are some obstetric simulation trainings also happening around emergencies, so around postpartum hemorrhage and medical complications like preeclampsia, um, neonatal resuscitation, transfers, and those are all really, really important trainings. But there was a gap, right, where we were just missing sort of the basic skills for what do you do when someone shows up in your ER or your parking lot about to give birth. So we went to Springerville, and that was our first site. And I'm going to go over with you some of the content of what we've covered in the training, but I also really want to talk about what the experience was like for us and for the various providers. So the first site we went to in Springerville, the EMS folks attended also along with the hospital staff, and it was mandatory by their assistant fire chief. And so they weren't super excited to be there. Tell you the truth, right? Because if you're there, are people like me who love birth, and when I hear someone in labor grunting or groaning, and I'm like, I go towards that noise, but really the rest of the world kind of goes the opposite direction. So as we were kind of introducing ourselves and getting to know each other, one of the firefighters was very transparent, and he's like, I don't want her delivering in my rig or his ambulance. He's like, because then I have to clean it up. And I had this moment where I looked at him, and everyone kind of chuckled because he was making a joke, but he was serious. And I looked back at him and I said, you know what? I said, odds are that person doesn't want to be with you either. Like that wasn't their plan to give birth in your ambulance or on the side of the road or in their bathroom for that matter. And I realized during that first pilot that maybe, just maybe, we could make this a better experience for everyone involved, for the providers who really are not working labor and delivery because they don't want to, but it is part of their job. And it's also for the people who are giving birth, like to my point, like they're not wanting to give birth in an ambulance. And can we make this a better experience all the way around for everybody? So, this image, you can see people are polite, they're paying attention. I'm talking to them about the different, cardinal movements about how babies move through the pelvis. But just body language, right? Folks are not super psyched necessarily to be at this training. And signups were a little challenging in the beginning as well. And we moved to sign up Genius with a QR code to make it a little bit easier, but getting people engaged in the very beginning was a little bit tricky because partly they kind of wanted the training. They had mixed feelings, right? I want the training because this makes me really uncomfortable and nervous to have to attend a birth, but I don't really want to do it, but I do want to do it. Very mixed feelings about it. But so let me talk a little bit about what we were covering and what we were training, and then we'll come back to the responses of folks. But we used one of the AIM bundles, the OB Emergencies Resource Kit, to build the trainings. There's a QR code to that if you're not familiar with that resource kit or if it would be of interest to you. And we focused on the section about readiness and introduced ideas before we got to the skills and the simulation about identifying who are your team, who are the folks in your community who have a little bit of interest in OB, are going to be your like champions and your go-to folks. And the readiness also helped us evaluate a little bit of a needs assessment for each of these communities, and they were all different. But do they have access to postpartum medications they might need? Do they have policies and procedures for how we're responding to a pregnant patient in our ED? And the policy, you might think, do we really need to write this down? But we learn from a safety perspective, we do. And so the image on the right is just a sample of a policy. And one of the basic things they say when somebody arrives is one of the first questions is, do they have a provider? Like, have they been getting prenatal care somewhere? And really important for two reasons. One, if these are daytime hours, we might have a good chance of getting records, right? It's always hard to care for a person when you don't have the background information. That always makes it easier if you can get it. And then the other thing we found for these communities is when they were needing to transfer someone to a higher level of care, sometimes they had a couple of options, and it might depend on volume at the next site. Like, could they accept the transfer? Were roads open related to snow, weather? Could they fly? So if we do know that there's a provider and we know where that provider is, ideally we want to get that patient to where their provider is and not actually fly them or send them, the other direction if possible. We talked a little bit about what transfer was like for them and communication levels. And for some, it was pretty kind of a pretty well-oiled machine for how they did transfers. And for other communities, it was actually pretty difficult. And they described having difficult communications around getting sites to accept patients from them sometimes, which that was a little surprising and hard to hear, but the reality, right, of rural health. And we also talked about the need for a little more remote capabilities enabled to do consultation or telehealth consultation that they thought would be helpful. We shared an algorithm that's from that AIM bundle, which in ERs, there are lots of algorithms about how we handle different emergency situations. This one is from a health system in Indiana, and it turned out to be super popular. Like, people were asking, can we print that out? Can you laminate it? Because it helps with the decision making about, do we transfer this person or do we keep them at our facility, which is always a challenge, right, in OB. So we talked about content, about getting, a focused history, right? And in EMS services or in the ED, they're already expert at getting a very narrow focus. What's the most important data? But we kind of highlighted what are the most important things in a pregnant situation, kind of content areas here listed to go over. We also covered supplies. Everyone's got a kit. Even in your ambulance, you've got a kit. But what's in that kit and what's helpful? What are the things that if you're grabbing the kit for your colleagues and you're opening it up, that what are the first couple of things to grab that are going to really be useful? We went over hand maneuvers. We talked about something called skin to skin and delayed cord clamping. So, for supplies, just as some examples, we talked about, gloves, the hat to retain heat for the newborn, having either the clamps or the umbilical clamps as a way to clamp the cord, a basin or something to put the placenta in, just giving them really like nuts and bolts. These are the things you're going to really want to have close by to you. Some of the other things, a drape is lovely, makes it a little bit easier to clean up after the birth, but do you need it in the moment of the birth? Not exactly. I would say the gloves are going to be a little more important. And we went over the cardinal movements, what's happening as the baby is coming through the pelvis to be born. And I gave them, one method of hand maneuvers to receive a baby. It's not the only way. It's not even necessarily the best way, but giving them something that they could kind of store, memorize, have some muscle memory around to increase their confidence when they were actually catching a baby. And sort of details of this. And you'll see there's a reference in one of the comments of a participant about the sandwich method of delivering a baby. And this is what they meant when you could see those two hands kind of sandwiching the baby's head. And we talked about skin to skin, which is putting mom and baby physically, not with a gown or a t-shirt or a towel between them, but physically putting their abdomen and chest together, which historically had been a little bit of, I would dare say, like midwifery woo-woo kind of thing to do. But we know there's really good evidence to keep mom and baby together, especially in that first hour. So I've got a reference for you on that slide that this is from a Cochrane Systemic Review from 2025, really summarizing this data. But this systemic review has caused one researcher to say it may even be unethical at this point for us not to put mom and baby physically together immediately after the birth, because it helps to stabilize the infant's body temperature. We know the maternal temperature can rise 1 to 2 degrees in response to the slightly lower temperature of the baby that's slightly damp, right, from coming from that fluid-filled environment. It can help facilitate breastfeeding if that's the plan for this birthing person, which also will stimulate some oxytocin release to help minimize the bleeding postpartum, right? So we're several benefits from that. And we talked about it benefiting bonding and depression. And I acknowledged if you're in an ER, you're trying to keep people alive. So thinking about bonding and depression is like nice, but doesn't feel real like mission critical to the work you're doing in an emergency room. And I get that. But if you kind of think back to the slides that we were looking at a few minutes ago, and I was talking about the increased risk of mental health diagnoses and having that now be the leading cause of death. If there's something as simple as putting mom and baby together right after the birth that might decrease postpartum depression and maybe have an impact on suicide rates among postpartum women, that's profound, and maybe a simple intervention that we can make that would help. World Health Organization also says that there's really strong evidence that looks to say this improves the neonatal transition and outcomes for babies. And then a reality is that it just gives you a place to put the baby. If this birth occurred in your facility parking lot or in the home, it gives you a place to put baby with mom while you're transporting them out to the ambulance or getting them on a stretcher and getting them into your facility, or even until a warmer arrives if you need it at all. The other thing we talked about was delayed cord clamping, which again, historically had been something that sometimes patients who had sought out midwifery care wanted to do delayed cord clamping. When I was training many, many moons ago, there was this rush to clamp the cord. We had this fear that almost like the entire maternal blood volume would pass into the baby, which when we think about it logically and how the umbilical cord is constructed, that's not going to happen. But a 2020 ACOG committee opinion said, given the benefits to most newborns, I'm going to read this for you, and concordant with our other professional organizations, ACOG recommended a delay in umbilical cord clamping for term and for preterm infants for at least 30 to 60 seconds after birth, right? So this is our physician colleagues also coming on board saying this is really best practice. They recently, in the last few months, September 2025, updated this committee opinion to say they extend it fully to 60 seconds and that cord milking, or sort of stripping along the umbilical cord to get that little bit of volume of blood that's in the cord to the fetus in that window of 28 to 36 plus 6 weeks is going to be helpful for that preterm baby. So even getting that little bit of volume. And the reason they're saying that is some preterm babies doing the delayed cord clamping and keeping them skin to skin on the mother may not be the most appropriate place for that baby to be in that first 60 seconds, right? If they're needing more support or resuscitation, we want to move them over to the warmer, but the provider can kind of strip that cord and get that little bit of volume of blood to the baby. So not necessarily what's going to happen for our emergency folks doing a precipitous preterm birth, but just to know that you can pause, you don't have to clamp the cord right away. And for our folks who are not usually in OB services, I said, this is a great moment for you literally to take a minute and pause. It's been a little bit of chaos probably as the person arrived or as you arrived to the person, the baby's out. Okay. Is the baby vigorous and crying? Baby's okay. Mom is okay. And I said, okay, now pause and look at yourself. Are you okay? Catch your breath. Look around the room, your colleagues. Is everybody else okay? Do we have the people present that we need? Is there anyone else that we need to call or notify to come be with us? So the delayed cord clamping is great for baby and mom, but it also helps those emergency folks kind of gather their thoughts and say, okay, let's reorganize. And in an emergency situation, you don't always get that opportunity to pause. So here we go back to that prior slide with the crossed arms and leaning back, right? Body language of like, I'm here. I don't really want to be. But now we've moved on to the hands-on skills. And I want you to look at each face. Now, I didn't see them, right? I looked at this photo afterwards and I'm like, wow, I'm just showing them this is what you do with your hands. This is how you're going to receive and catch this baby. But I was amazed to see how intently they were all following along and watching and learning. And then they started to do it themselves. And there's a smile on every single one of the faces in this image as they started to get hands-on. So the folks who were like, I don't want to be here, really had a shift, a real significant shift in their mindset by the time they were done with us. And so this shows up in the data. I have a couple of bar graphs here just to show you. This is just looking at confidence level. And on the left, you can see the orange is in the pre-training, right? So the majority of people in the beginning were feeling, maybe I'm a little bit confident, but a good 50% or more said, I don't feel confident at all, or like I'm somewhat, but really not confident about managing and being with a pregnant person in labor. Another image, here we are engaging. This isn't a high five. I know it looks like it, but we were doing hands-on pressure. Precipitous babies, they come fast. And one of the things we were talking about is how do you slow that baby down? We're not trying to stop it, not trying to push it back, but how do you just control how quickly that baby's head comes out to minimize tissue damage for the mom, for that pregnant person. And so here we are kind of leaning our hands into each other so I can demonstrate. This is about how much pressure you might be able to apply on a term baby's head as they are being born. So when we look back again to confidence, so orange is pre-training, blue is post. And this question was about supporting the newborn in their transition to extrauterine life. Not confident at all. Really significantly an increase in confidence, and even folks feeling very confident by the time they left our training. And I love these two. Very happy. They had fun catching babies with us. So the overall training with this 3D kind of bar graph shows the pre-training responses, the post-training responses, and with each question kind of summarizing how do you feel, the first one about being with a person in labor, obviously much more confident. How do you feel about knowing what supplies you actually need for a birth? Confident. Knowing what the maneuvers are and how to demonstrate how to catch a baby. Everyone's worried about dropping the baby, right? We've had no drops in our training so far. And what was their, how confident they felt about transitioning the newborn. So I'm going to show you a very short video. This is when we were in, I think this was La Paz. And this was a family practice physician who was attended one of our trainings and asked me as we had gotten through the births, he said, do you think we could do a shoulder dystocia? And last time I had that experience was in residency. That was several years ago. It's the one thing that keeps me up at night. And if you are not an obstetric person, what shoulder dystocia is simply is when the baby's being born, the head comes out and then the shoulders are stuck, usually behind the mother's pubic bone. And pulling on a baby will not get this baby out. It will only cause nerve damage to that arm that's stuck. So there are some maneuvers that you need to do to get the baby out. It is probably the obstetric complication that gives the most fear and stress to physicians, midwives, any providers. So you won't necessarily hear all of the conversation. That's okay. I want you to notice three things. One, as he realizes that feeling of the head is not coming out, even though he knows that's what's going to happen because he asked me to do that, right? To see that feeling, to see how everyone cheers for him once he does get that posterior arm out and delivers the baby. And something I've just noticed recently is that one of the nurses on the far, far right of the screen is starting to put her gloves on as we're working through the simulation, as if this is a real scenario and she's going to jump in and help him. It's just the power of simulation. So I will be quiet so you can hear.
Do you have the volume up high? Because we can't hear it.
Oh, yes, I do, but I will make it higher.
I think there is, um, there's a,
Was everybody having trouble hearing? Is there anybody else can just give me a yes or we're okay, Mariah?
I haven't heard any, but I did believe when we previewed it, there was a second or two in the beginning. I can hear it.
We're going to need to remove the pressure. Two hands, maybe space it towards the door. We're going to have you put your hand right here and point it downward. Pressure to the door. Okay, I'm going to need to try and straighten the back right on.
oh, Denise said she can't hear it. Turn your volume all the way up.
It is. It's all the way up.
Oh, Denise, I had to turn my volume all the way up.
Yeah.
Stop him right there. Sorry, I went to restart. So I will say that, if you weren't able to hear it in the beginning, but there was just that moment when he realizes he can feel in his hands that this baby is not coming, it's stuck. And he was looked up at me and he was like, oh, this is that terrible feeling. And we were able to coach him through the maneuvers so that he could deliver that shoulder. And then everyone else in the room, right, cheered and was like, oh, great, you did a great job. If there's any obstetric providers on this call, I know we did debrief. Not everything was perfect, so please don't be super critical, but we did talk afterwards about, things that he could do in the future. But I was really proud of him and he did a great job. So I'm going to move us on to our next slide to talk about some of the comments. I personally will not deliver the baby. So we did have a couple respiratory therapists and like a scrub tech at some of the hospitals. So there's lots of different providers, but they said, I feel I can make a recommendation as to how to use that sandwich technique to bring baby out. Because we talked about how, as a team, having this knowledge, you may be the one who catches the baby, you may not, but you can help your colleague who's maybe nervous or struggling in the setting and be able to share that information together. Feeling that the manual demonstration, not just slides, they enjoyed my energy. That was great. And they enjoyed the hands-on practice. And they said, okay, so this is for our EMS folks, that we know we can deliver a baby if we're not able to drive fast enough or to get to that next facility. And that they felt the hands-on training was really amazing to help them feel more confident for when they know that these non-birthing hospitals and EMS folks that are not OB providers, but they sure as heck are birthing babies in our communities. So some lessons that we learned going from our pilot, but going to the other hospitals that we've been to, schedule the sessions around the provider's shifts. So being sure that we're meeting them where they are at on site was really powerful versus if we had to bring folks here. I think, in my professional opinion, about 8 learners was good for that class size. We did use Sign Up Genius, ended up being a really great way to schedule things, building in some breaks between the sessions for the trainers. That first one in Springerville, I think, Jill, we can see your face now. Great. I'm so glad we can see you. We did 5 2-hour sessions back to back without a break between them. And that was poor planning on my part. We need nutrition, hydration, bio breaks. We added with the grant, we added the evaluation for continuous improvement over the trainings. Providing some free CEUs was super helpful as well. Making sure we had a sign-in sheet, but especially a media release so that we could have some of these great images. And we did provide additional resources around maternal mental health for those communities, because we know these are, especially in the ER, they're going to be seeing postpartum people having a multitude of physical symptoms that may also be behavioral health related. And clinically, what we learned was that it was very helpful to be clear about the scope of practice for each role. And while EMS and the ER folks see each other fairly regularly, it's a pretty brief interaction as they're bringing in and dropping off and leaving again. So this was a 2-hour time block together where we talked a little bit and folks were able to see, oh, what's different about EMS? For example, they don't deliver the placenta. That's not within the scope of practice unless the placenta is coming out spontaneously on its own. And so for some hospital folks, they might have felt like, why are they leaving the placenta in there? They left it for us to take care of, right? So simple things like that were just misunderstandings. So understanding roles and responsibilities. In the first trainings, I realized it was important to include a trigger warning, which we did. Sometimes in OB, and when we talk about babies being born quickly, these are stories on the news. Sometimes there's fun and there's some humor around that. But we did need to acknowledge that the people who are attending our trainings either personally may have had a pregnancy or a birth experience that was traumatic or that was a loss, or for some of them as providers, they may have had an experience that was difficult, and giving people space or giving them a heads up, hey, if you may have that happen today, and if you do, or you need space and need to walk out of the room, please feel free to do that. Don't feel like you have to stay contained if you're feeling some discomfort. And we had to be flexible with the trainings because each community was a little different about what their transportation was like, whether weather impacted that and climate, and what their partnerships were like. And I already mentioned to you that algorithm was very popular, the go, no go algorithm. And the last things I want to talk about here, and hopefully have a little, conversation, Jill and I have mentioned, doing these trainings has been amazing, and we've met wonderful people who are providing care in our rural communities. But we still have a really shortage of providers around the state and abilities to offer services. And thinking that traditionally a 24/7 OBGYN physician coverage labor and delivery unit is just not sustainable for not just most, but really almost any of the smaller rural communities. So I would say we really need to think creatively about how we're providing obstetric care in the state of Arizona. So when our resources are limited, we have to use them efficiently. And I think it's going to be different for each community. But what are our provider resources? So yes, our OBGYN physicians are really important members of our team. And we really need them where we have maximum use of their resources, right? Who else can provide obstetric care? We've got family practice physicians who are trained to do OB services, and that's an important part of the work that they do. For some of them, I understand you can also get a certification. So some family practice docs can do training for cesarean section, even though they're not trained surgically the way an OBGYN is. That's something they can add. You've got certified nurse midwives that are licensed by the Board of Nursing in the state, and they provide reproductive women's health care from menarche all the way through menopause. In Arizona, the Department of Health and Services also licenses certified professional midwives who are not nurses. They have a narrower scope of practice. It's pregnancy, prenatal care, birth, and that immediate postpartum period. CPMs often practice in home settings, but also in birth centers around the state. And so I think that's a really interesting provider that we might really think about having. Is there potential to have CPMs and CNMs in our more rural communities? Physician assistants, once they are graduated and licensed, they also can obtain an additional obstetric certification that would allow them to not only, prenatal care is part of their general training, but to be part of the birth community and in hospital settings. Now, our nurse practitioner colleagues that are practicing in rural settings, family nurse practitioners, for example, they may want to do a postgraduate certificate and have a dual certification and be a nurse midwife and an FNP. And then remembering, the education and training for our EMTs and paramedics that are currently providing birthing care also in our rural communities. So I just wanted to raise the issue that these are all the types of providers who might be able to provide obstetric care. And as we discuss in a few minutes, you may have thought of some others. On my last slide, I want to just think about some creative solutions, such as looking at the providers we have in a rural community and say, are there any certifications that we can add? So without even bringing another body to your community, are there trainings that we can add for folks to build their skill set? We also would then need to create partnerships. So those folks who are dual certified can maintain their skill set, especially because that's one of the tricky issues in those lower volume communities. Looking at a birth center model versus a full service, if you will, labor and delivery unit, can we offer some basic obstetrics services for a low risk population? Nitrous oxide, sometimes referred to as laughing gas, having that available in your facility if you don't have access to a CRNA or anesthesiologist, if that's not available. I am highlighting here White River Birthing Center. I have not visited there yet. I learned about this through another presentation that I attended and in talking with some of the folks at some of the other critical access hospitals. So if there's anyone on this call from White River, that would be great. Please interject. But they operate a birthing center within their hospital. They take care of low risk women. They're not able to offer epidural services. So for someone who wants an epidural, they're going to move on to, I think, Sholo, if I remember correctly, or that Dignity Hospital would be the closest. But if they were low risk, there were obstetric nurses and a provider that could be available to do the birth in their facility without having to travel. If they do need a cesarean section, again, they would also need to travel to the other facility, which is really very much the way the birth centers that we have around the Phoenix area in the Valley and some of our rural communities do have some accredited AABC birth centers as well. There may be some expansion opportunity to expand that model. And, we're transferring already high risk folks, but early identification is clear and key. And we need to make sure that everyone knows what the plan is, especially when someone has been able to have prenatal care. We want to increase that access so that we're able to do risk assessment and know who are the folks in advance who have to make it to Tuba City, who have to make it into Phoenix or make it to Yuma. And there's a couple of ways we can increase prenatal care access with mobile units, maybe adding prenatal services, not every day, but at least one day a week in some of the rural communities. Telehealth, right? There's a lot of work that's been done around that, especially since COVID. And then looking at, are there other providers that can be doing home visits to do some beginning education and prenatal assessment? And that, might be with RNs or CPMs, and even around education and risk assessment using our community health workers as well. So I'm going to pause there. We have 11 minutes. That's great. To see if you have questions or if anyone wants to explore some of the, how are we going to solve this problem about access? I'll be quiet.
Yeah, I will open the chat for any additional questions. I can also unmute participants if you would like that to verbally ask your question. So if you're wanting unmuted, please just put it in the chat and I can do that for you. I did have one question come up, and it's mainly about workforce. So it's talking about with the proposed reclassification of professional degrees, do you see that potentially impacting access and the workforce in these areas?
Yes, absolutely. That is something that we've been talking about because, especially as that affects nurses and nurse practitioners and nurse midwives, and having access to student loan funding for professional education. So I know that folks are writing in and contacting legislatures, but nursing is working pretty aggressively to have that language changed and to be sure that they get added back in.
Okay, thank you. And then the other one is just how do you see this program continuing to grow and develop? Are you looking to train trainers? How do you want it to continue?
Yeah, and we've been talking about that, and we're open to suggestions, but really we would need to look at funding again. So, looking at some additional grants, really around transportation. I mean, I have to say, this is so fun. You know, I will just do it, right? For me personally, I don't feel like I need to be paid. It feels to me like it's part of my university work. However, though, to be sustainable, right, folks are going to need to have this training, even if it's abbreviated again, so they can refresh themselves. We've talked about do we record something so that people can look back and remember and go, oh, yeah, yes. Okay. But I think the hands on piece, we got a lot of feedback to say that was meaningful and important. So I think having something where we're able to continue to travel around to the communities to do this training would be ideal. And maybe, coordinating the efforts around obstetric simulation training, with the other entities that are doing this work so that we can streamline it and coordinate our efforts. Jill, do you have other thoughts? I just jumped in and answered them.
Yeah, you didn't really mention the mannequin Sophie in Mom. That's the mannequin that Erin prefers. And Sophie's the baby, Mom is the pelvic area, and that baby is 6.5 pounds and feels so real that when they do catch this baby, they're like, wow, does that feel real? So that hands-on is really crucial, I think. So we're going to have to figure out how often we revisit the hospitals. They always have such a big turnover in staff. So, just being able to keep this going, I think is so important.
Thank you. And then I don't see any other questions in the chat, but I did want to ask if there's hospitals or clinics or even midwives or nurses that want to get involved in this. How do they do that?
That's great. So folks can reach out to either Jill or myself. If folks are interested in midwifery, is what I can speak to most. So currently at the University of Arizona, we have a program in our College of Nursing that's within our Doctorate of Nursing practice. So any RNs that are interested in seeking that education and training can reach out to the College of Nursing to find out. And it is a hybrid program. So regardless of where folks live in the state, they can do the bulk of their education within their home community with a couple of visits down to Tucson to do some of this hands-on experience. And
I put our
Dr.
email,
Carabus, yeah,
I
Dr.
put our
Carabus,
emails in the chat, but you have to put it out to everybody. Sorry.
that's okay. I just wanted to say that Dr. Kara Busenhart is the specialty coordinator for that program now at the College of Nursing and is on our call with us today.
Perfect. Thank you guys so much for your time today. Really appreciate the information and this program. Coming from the Center for Rural Health, it's been really cool to see it grow from an idea into practice. Carrie, I saw you come on camera. Is there anything else you'd like to add? No? Okay, perfect. Have a great day, everyone. Thank you so
Thanks,
much for your
everyone.
time.
Bye-bye.
Thanks for attending, everyone.